welcome back to my channel. So today we'll discuss some important questions for pharmacology, especially focusing on the antitubercular and antidepressant drugs. So today let's talk about antitubercular and anti-leprosy drugs. So I'll tell you how the question will be asked in your examination. So the question will be like, enumerate anti-tubercular drugs and describe the mechanism of action, adverse effects, and therapeutic uses of rifampicin. So they are focusing on a particular drug like rifampicin, and they're also talking about the different drugs like classification and mechanism of action, adverse effects, and therapeutic uses of rifampicin. So anti-tubercular drugs will deal about the classification of anti-tubercular drugs. After the classification, we'll deal with the rifampicin, also with the pyrazinamide part, and drugs regimen in drug sensitive TB, second line anti-tubercular and MAC infection. Okay, so let's talk about anti-tubercular drugs. So if you classify the anti-tubercular drugs, so in anti-tubercular drugs it will be first line drugs. First line drugs you have first line drugs, in that you have HRZES regimen. In that you have HRZES regimen. In first line drugs you have HRZES regimen. In the second line drug you have fluoroquinolones. You have other oral drugs. You have injectable drugs. You have injectable drugs. You have injectable drugs. So let's talk about these. So in the first one, as you see, in the first line drugs, you will find that there is a HRZE. HRZES. H is for isoniazid. You can write isoniazid as INH, or you can write as or you can write as H. So you can write as INH or H or isoniazid. Okay. So these are the ways you can write. Other drug is the rifampicin. Rifampicin you can rifampin R, and pyrazinamide as Z. Okay. Ethambutol as E, and isaptomycin as S. But among these first line drugs, the HRZE are the oral, whereas streptomycin is given as IM injection. Okay. Talking about the second line drugs, in second line drugs you have fluoroquinolones. In fluoroquinolones you have ofloxacin, levofloxacin, moxifloxacin, and ciprofloxacin. Floxacin as suffix you have in these fluoroquinolones, floxacin, oflofloxacin, levofloxacin, moxifloxacin, and ciprofloxacin. Okay. Talking about injectables, so you have to remember only three injectables are there. These are kanamycin, amikacin, and capreomycin. Kanamycin, amikacin, and capreomycin. These fluoroquinolones you can remember as oh my lord. Oh my lord drugs, oflofloxacin, moxifloxacin, and levofloxacin. Oh my lord, and you can remember ciprofloxacin. Other oral drugs, see, the first line drugs are used for the general TB, but second line drugs are used in those who have not cured after the treatment, or those who have developed resistance against the TB bacilli, against the first line drugs. Okay, against the first line drugs, if they have developed any resistance, then we go for the second line drugs. So in second line drugs, that's why you are very sure, oh my lord, they are using the second line drugs like fluoroquinolones. Okay. Other drugs you can have not ethambutol, ethionamide. So you have ethionamide, you have cycloserine, you have PAS is para-amino salicylic acid, and rifabutin. Okay. Injectable drugs you have kanamycin, amikacin, and capreomycin. Talking about anti-tubercular drugs, in anti-tubercular drugs you have the group 1 first line drugs, you have group 2 first line drugs, you have group 3 drugs. So you have different drugs. First line drugs, these are the drugs which are taken as the orally. These are the drugs which are taken as the orally. So these are the drugs which are taken as the orally. So these are the drugs which are taken as orally. Group 1 first line oral drugs, second line injectable drugs, septomycin, kanamycin, amikacin, capreomycin. Group 3 fluoroquinolones, oflofloxacin, levofloxacin, moxifloxacin, ciprofloxacin. Group 4 drugs, ethionamide, prothionamide, cycloserine, tazidone, para-aminosalicylic acid. Group 4 is about unclear efficacy drug, thiacetone, clarithromycin, clofazimine, and linezolid. So these are the drugs. So talking about alternative classification, you have divided into five classes, one to five classes. First drug you have the first line oral drugs. Second you have injections. So streptomycin was first included in the first line drug, but this streptomycin is not orally taken; it is taken by IM injection, so it is included in injectable drugs. Then you have group 3 fluoroquinolones. In fluoroquinolones, you will find oflofloxacin, flevofloxacin, moxicillin. Group 4 drugs. These four drugs are the other drugs. Okay, these are ethionamide, prothionamide, cycloserine, and para-aminosalicylic acid. Group 5 is clarithromycin. These are unclear efficacy drugs. Linezolid, clarithromycin, amoxicillin, like that drugs. Let's talk about first isoniazid INH. Okay, isoniazid INH. Okay, talking about isoniazid. So isoniazid is an excellent antitubercular drug. It is the primary tuberculocidal drug. It acts on the focus on this sentence. It acts on the fast multiplying. It acts on the fast multiplying bacteria. Fast multiplying organisms are rapidly killed, and quiescent ones are only inhibited. So fast multiplying one are killed. Fast multiplying one are killed. Okay, fast multiplying organisms are rapidly killed, and the quiescent ones, which are present at the spores, they are also inhibited. It acts on extracellular bacteria, so it acts on the extracellular bacteria as well as on the intracellular bacteria. So it's a very good drug. It is rapidly killing the multiplying bacteria so that the patient will not have the symptoms. It is also inhibiting the quiescent ones, which are in the form of spores. So this is acting as extracellular and intracellular. So bacilli present with macrophages and is equally active in acidic or alkaline medium. So it is equally active in acidic and or alkaline medium. Okay, so it is a fast multiplying organism. It is rapidly killing quiescent ones. Also, it is inhibiting. It is both extracellular as well as intracellular. Such a nice drug. That's why if they are getting resistance, so then it's difficult to treat the TB. They have to use the second line drugs, which are not that much effective when compared to this. So isoniazid enters sensitive. So the mechanism of action is very important. So what isoniazid does, it enters into the, it acts as a catalyst as the peroxidase, and it becomes active metabolite, and it adducts with NAD or an NADP. See here what it does. So nice table form is there. It will flowchart form. So NAD adduct which is there. NAD adduct which is there. NAD adduct. NAD adduct, it inhibits INHA and Cas-A gene so that mycolic acid synthesis is interfered. NADP adduct is there. It inhibits mycobacterial DHFRase gene, which causes the DNA synthesis is interrupted. Is interrupted. If you see here carefully, you can see that isoniazid, it is uh, converted into active metabolite, and it adducts with NAD and NADP. It adducts with NAD and NADP. So isoniazid, it adducts with the NAD and NADP. Isoniazid adducts with NAD and NADP. So so it joins, adducts means it joins them, NAD and NADP. So isoniazid NAD adduct. It is a covalent bond between the antitubercular drug INH and the NAD cofactor. So it joins. Like suppose we have here isoniazid. So it will join. It will join the NAD. Okay, let's take NAD. So it will join the NAD. So here we have isoniazid. It is joining with the NAD. It is joining with the NAD by a covalent bond between them. So this adduct inhibits INHA. INHA is an enzyme. INHA is an enzyme in mycobacterium that is involved in the synthesis of the INHA. It inhibits INHA. So INHA is the enzyme which is involved in the synthesis of the mycolic acid, and this adduct is a slow tight binding inhibitor of INHA. So the it inhibits INHA. So what will happen if INHA is inhibited? If the INHA is inhibited, mycolic acid synthesis will not take place. Okay, one more adduct is formed, that is NADP adduct. This inhibits mycolic DHFRase enzyme. So this DNA synthesis is interrupted. DNA synthesis is interrupted. So this is the mechanism of action. Once again, let me repeat so that it will be easy. So see here, isoniazid, it is coming into your body. It is getting active metabolite. Then it adducts with the NAD or NADP. Okay, it needs the peroxidase enzyme. Because of the peroxidase enzyme deficiency is taking place here. Yeah, because of this reaction, peroxidase is getting deficient. So NAD adduct is formed. This NAD adduct inhibits INHA, and this is causing mycolic acid synthesis interference. NADP adduct, it inhibits the mycobacterial DHFRase, and it inhibits the synthesis of the DNA. So here isoniazid is doing two things. It is inhibiting the synthesis of mycolic acid, it is also inhibiting the synthesis of DNA. So now bacteria cannot survive. So it acts on both rapidly dividing bacteria and killing them. Also, it inhibits the spores, right? Other thing is it is both intracellular and extracellular. Talking about resistance, the most common mutation is cat G gene mutation. Here cat G gene is mutated. Here cat G gene is mutated, which reduces catalase peroxidase. So cat-G gene is responsible for conversion of isoniazid to active isoniazid. So because of this inhibition, mutation of cat-G gene, the peroxidase, catalase peroxidase enzyme is inhibited. So other mutations are the INHA gene and Cas-A gene mutation. So the cat gene mutation, cat gene is responsible for the catalase peroxidase. Cat gene is responsible for catalase peroxidase. So when cat gene is mutated, as soon as it cannot convert to active metabolite, and okay, if the cat gene is normal, everything is normal, it convert into active metabolite. After that, adducts of NAD and ADP is formed, but this adduct here INHA gene is mutated. Because of it, the adduct is not able to inhibit this INHA, NAD and NADP KSA gene. KSA gene. Okay, so these are the things taking place. KCNH gene NAD adduct. Okay, talking about the pharmacokinetics, and it's completely orally absorbed, so it can be given orally, and penetrates all body tissues. It penetrates all body tissues. So tuberculous cavities like placenta, blood-brain barrier, meninges, everything can be treated. It's extensively metabolized in our most important pathway being N-acetyl. N-acetyl by NAT2 enzyme. So it is converted by acetylation. So the acetyl metabolite is excreted in urine. So if liver failure is there, then the NAT2 enzyme will be defective. Then it cannot be metabolized, so it can cause the neural defects. Interaction aluminum hydroxide inhibits INH absorption. So if you are taking aluminum hydroxide, this aluminum hydroxide people usually take for acidity. So if aluminum hydroxide is there, it will interfere with absorption, it will inhibit the absorption. Retards phenytoin comes with diazepam, theophylline, and warfarin metabolism by inhibiting and may raise their blood levels. So, if blood levels of these are raised, then what will happen? These can cause the toxicity. So, warfarin, carbamazepine, phenytoin, and diazepam, and theophylline. These are what? These are usually given for the. These are usually given for the uh, these carbamazepine, phenytoin, diazepam for sleeping. So they will be the metabolism is inhibited by CYP 2C19 and CYP3A4 and may raise their blood pressure. Okay, adverse effects is peripheral neuritis. Remember the adverse effects I'm marking with the red one. Adverse effects is very important. Peripheral neuritis can be overcome by giving pyridoxine. If there is a this is neurological manifestation. If anus neurotoxicity is treated by neurotoxicity treat with 100 mg, 100 mg pyridoxine. Okay, hepatitis it can cause liver problems. Hepatitis. Talking about other side effects, if you talk about side effects, lethargy, rashes, fever, acne, arthralgia. Okay, other side effects is joint pain, acne, fever, rashes, lethargy, all will be there. Rifampin. Talking about the rifampin is semi-synthetic derivative of rifampicin. First line antitubercular drug, and it kills both intracellular and extracellular bacilli. It also has resistant preventing actions. So rifampicin is a semi-synthetic derivative of rifampin. Rifamycin semi-synthetic derivative is rifampin, also called rifampicin. First line antitubercular. It kills both. It also kills both intracellular as well as extracellular bacilli. Users are marking with blue. Okay. It has also developed resistance preventing its action. Now I'll discuss the mechanism of action with green. Okay. So see here mechanism of action. Rifampicin already it is there in green. We'll go for black. So rifampicin binds to beta subunit of mycobacterial DNA dependent RNA polymerase beta subunit. It interrupts the DNA synthesis. If DNA synthesis is interrupted, the bacteria will die. So the mechanism of action is simple only. See here, rifampicin binds to beta subunit of mycobacterial DNA dependent RNA polymerase interrupts DNA synthesis. So what it does, what it does, it is actually binding to the RNA polymerase enzyme and interrupting the DNA synthesis. Rifampicin binds to beta subunit of mycobacterial DNA dependent RNA polymerase. Pharmacokinetics. It is orally well absorbed from GIT, but food reduces its absorption. Food reduces its absorption. Okay, distributed widely across the body. It is metabolized by liver, actively deacylated from undergoing enterohepatic circulation. Form undergoes enterohepatic circulation. It excreted in urine and bile. If you talk about interaction, microsomal enzyme inducer CYP50 or CYP3A4, etc. Talking about the uses, so uses is of leprosy is the leprosy. It is used in leprosy, tuberculosis. Rifampicin also used in leprosy because it's very effective. If it is not resistant to it, it is very effective. Prophylaxis of meningococcal and H influenza. So prophylaxis of meningococcal and H influenza meningitis. And second and third choice for MRSA, diphtheroids and Legionella. But the first line therapy for brucellosis, doxycycline, rifampicin along with doxycycline, first line for brucellosis. First line for brucellosis is doxycycline plus rifampicin. Doxycycline plus rifampicin. Okay, talking about adverse effects, same hepatitis, it can also cause hepatitis, flushing, rashes, headache, malaise, nausea, vomiting, diarrhea, orange red urine. This is important. If the patient is taking rifampicin, he will see that his urine color is changed. He will be worried about this. Even the body secretions like tears and all will get red. If the patient's taking rifampicin, the contact lenses turn to red, orange red. So that is because of the rifampicin. It's a harmless adverse effect. Okay, that the patient should be first explained about it that this is going to happen, or else he will worry a lot. He or she will worry a lot. Right. So it is also used for meningococcal prophylaxis. Okay, for leprosy. This is important for brucellosis. It is as the first line of choice. Doxycycline plus rifampicin. Mechanism of action is also simple. Rifampicin binds to subunit of DNA-dependent RNA polymerase and interrupts the DNA synthesis. Beta subunit of the enzyme DNA dependent RNA polymerase. So this was about the thing. If they are going to ask you, key, tell me about the mechanism of action. Describe the mechanism of action with rifampicin. What you will tell? That the it binds and inhibit the it binds to the beta subunit of the the DNA dependent RNA polymerase of mycobacteria and causes DNA synthesis inhibition. Okay, due to inhibition, the bacteria will die. Okay, talking about the adverse effects are the orange red color urine, hepatitis, because it is also metabolized, pharmacokinetics is metabolized in liver, active deacylated active deacylated form undergoes hepatic circulation, vomiting, headache, the GI symptoms, nausea, vomiting, diarrhea, headache, malaise, rashes, flushing, hepatitis. Okay, okay, allergic symptoms. Adverse effects, these are the adverse effects. Talking about therapeutic uses of rifampicin, therapeutically this can be used in leprosy also, and tuberculosis का तो use होता है ये, leprosy also, and prophylaxis of meningococcal and H influenza meningitis, prophylaxis of meningococcal and H influenza meningitis. And second and third drug of choice for MRSA, if vancomycin cannot be given, if last choice is there, you can also go for rifampicin, but it is mostly used for tuberculosis and leprosy. Diphtheroids and Legionella infection, it is in combination with doxycycline. Brucellosis is the first line of drug. So I think rifampicin is clear. If you are getting question as nisoniazid, they're asking mechanism of action. So what you will tell, isoniazid by the catalase peroxidase, it is converted to active metabolite. Then it adduct with NAD and NADP. If it is adducting with NAD, it will inhibit the INA and Cas A gene, INHA and Cas A gene causing mycolic acid synthesis inhibition. If NADP adduct is formed, then inhibits mycobacterial DHRase, which is inhibiting the DNA synthesis, and because of that, the bacteria will die ultimately. So NAD adduct inhibits INHA and Cas A gene. Remember the gene Cas A gene and NHA for the synthesis of the mycolic acid, and DHFR is gene. DHFR is for DNA synthesis, and catalase peroxidase for the active metabolite of isoniazid. But if CART gene is mutated, what will happen? Produce the it will not be able to produce catalase peroxidase. Other mutations of NHA gene and Cas gene, mycolic acid synthesis will not be inhibited. So INH is completely absorbed orally. You can give, penetrates all body tissues, tubercular cavities, placenta, blood-brain barrier, and meninges, everything. Okay? Extensively metabolized in liver. Most important pathway of metabolizing is N-acetylation by NAT2 enzyme in the liver, so, and it is excreted in urine. Okay, drug interactions, aluminum hydroxide inhibit the INH absorption. INH retards the phenytoin, carbamazepine, diazepam, theophylline, warfarin, and inhibit the metabolism by CYP2C19 and CYP3A4, and may rise the blood levels. Adverse effects, peripheral neuritis. For that, you can give pyridoxine 10 mg as the prophylactic in diabetic patients, pregnant women, lactating women, and neurological manifestations can be there because of peripheral neuritis and nerves affected. INS neurotoxicity is treated by 100 mg, and hepatitis and other side effects, lethargy, rashes, fever, acne, arthralgia, body pains. Okay, rashes, lethargy, fever, acne. So this is all about these tubercular drugs. What next we can talk about? Let's talk about the other drug, that is pyrazinamide. So HRZ, talking about pyrazinamide, it is weakly tuberculocidal, not very good like rifampicin, isoniazid. First line drug, it is active in acidic medium, more lethal to intracellular bacteria. If the bacteria is inside the cell, then it is more lethal to it. Pyrazinamide mechanism of action, it acts on pyrazinamidase acts on pyrazinamide to form pyrazinoic acid, which gets accumulated in acidic pH, inhibits mycolic acid synthesis. So, talking about mechanism of action, what will happen? There is an enzyme called pyrazinamidase. Ase enzyme pyrazinamidase. It acts on pyrazinamide to form pyrazonic acid, which gets accumulated in acidic pH and inhibits mycolic acid synthesis. So there is an enzyme called pyrazinamidase. This enzyme acts on pyrazinamide to form the pyrazinamide will convert to pyrazinoic acid. This pyrazinoic acid is accumulated in the acidic pH and inhibit the synthesis of the mycolic acid. Talking about other actions, it disrupts mycobacterial cell wall. Cell wall is disrupted and it disrupts the transport function. Pharmacokinetic, it is well absorbed orally, good penetration CSF, so it can be highly used in TB meningitis. Metabolism, metabolized in liver, excreted in urine, safe in pregnancy. So you have to talk about how it is given. ADME, you have to talk about absorption, distribution, metabolism, excretion. So it is metabolized in liver, excreted in urine, safe in pregnancy. Okay, and distribution, it is distributed to CSF, very good for meningeal TB. Talking about administration, then it is by the orally absorbed. Okay, adverse effects, hepatotoxicity. If liver में मेटाबोलाइज हो रहा है हेपाटोटॉक्सिसिटी, यूरिन से हो रहा है हाइपरयूरिसीमिया, abdominal distress, arthralgia, flushing, rashes. Okay, I think pyrazinamide is clear now. Drug regimen in drug sensitive TB. If drug sensitive TB means no resistance is there. Then intensive phase 2 महीने के लिए अच्छा जेडी चलाओ, उसके बाद अच्छा 4 महीने 6 महीने तक यू आर फ्री ऑफ टीबी. ठीक है, 2 महीने तक आपको 4 दवाइयाँ खाना है, उसके बाद आपको सिर्फ 3 दवा खाना है 4 महीने के लिए, उसके 6 महीने तक आपका ट्रीटमेंट हो जाएगा. 2 महीने इंटेंसिव फेस रहेगा. ठीक है. टॉकिंग अबाउट प्रीवियसली ट्रीटेड और फिर भी आपका ठीक नहीं हुआ है, तो आप HRZES 2 महीने के लिए लेना पड़ेगा, फिर HRZE 1 महीने के लिए लेना पड़ेगा. ये इंटेंसिव फेज है. उसके बाद HRE 5 महीने के लिए लेंगे. टोटल आपको 8 महीने तक का ट्रीटमेंट कराना होगा. 8 महीने क्यों, यहाँ पे 1 महीना बढ़ा और यहाँ पे 1 महीना, एक एक महीना. ठीक है, ठीक है. HRZES ये आपका फर्स्ट लाइन ड्रग्स है. दिस आर ड्रग सेंसिटिव टीबी. इंटेंसिव फेज 2 महीने के लिए चलेगा. अगर आप पहली बार ट्रीटमेंट ले रहे हैं, न्यू पेशेंट है, पहली बार टीबी हुआ है, और कंटिन्यूएशन फेज में 4 लेना पड़ेगा. प्रीवियसली ट्रीटेड है लेकिन कोई रेसिस्टेंस वगैरह नहीं है, तो आप HRZES 2 महीने के लिए जा सकते हैं. फिर HRZE 1 महीने के लिए रहेगा. HRE 5 महीने के लिए लेना पड़ेगा. और अगर आपका ऑलरेडी फर्स्ट टाइम हुआ है, कोई रेसिस्टेंस नहीं है, तो HRE 4 महीने के लिए लेना पड़ेगा. 6 महीने का ट्रीटमेंट रहेगा. For second line anti-tubercular drugs, second line anti-tubercular drugs में आपको इंजेक्टेबल्स है कैनामाइसिन, एमिकासिन, कैप्रियोमाइसिन, इथेनामाइड एंड फ्लोरोकिनोन. एक फ्लोरोकिनोन एंड इथेनामाइड. ठीक है. ड्रग रेजिमेन इन मैक इन्फेक्शन. मैक इन्फेक्शन क्या चीज़ है भाई? सो टॉकिंग अबाउट मैक इन्फेक्शन, तो मैक इन्फेक्शन है माइकोबैक्टीरियम एवियम कॉम्प्लेक्स. मतलब ये नॉर्मल टीबी नहीं है, ये उन पेशेंट में नहीं होता है जिसका इम्यून सप्रेशन है. Okay, like AIDS in HIV patients. Talking about the clarithromycin जो है, क्लैरिथ्रोमाइसिन है 500 mg देना पड़ेगा. क्लैरिथ्रोमाइसिन 500 mg देना पड़ेगा ट्वाइस डेली, 2 बार देना पड़ेगा. लेकिन अगर आप 2 बार नहीं लेना चाहते हैं तो 500 mg एजिथ्रोमाइसिन रोज़ एक दिन ले लो. ठीक है. इथैम्ब्यूटॉल 1000 mg 15 mg पर kg के हिसाब से लेना रहता है पर डे. एंड रिफाब्यूटिन लेना है. ब्यूटिन रिफेम्पिसिन नहीं है, रिफाब्यूटिन है. 300 mg पर डे लेना होगा. ठीक है. उसके साथ साथ इंटेंसिव फेज में ये 3 ड्रग्स हो गए. सिप्रोफ्लॉक्सासिन लेना होगा, लीवोफ्लॉक्सासिन, मॉक्सीफ्लॉक्सासिन, कोई एक ले सकते हो, कोई एक. ठीक है, कोई एक ये फ्लॉक्सासिन से. ठीक है, कोई एक आप ले सकते हो इसमें से. मेंटेनेंस फेज में क्लैरिथ्रोमाइसिन, एजिथ्रोमाइसिन, इथैम्ब्यूटॉल, रिफाब्यूटिन, 1 फ्लोरोक्विनोन. डोसेज इन मेंटेनेंस डोज आर द सेम एज द इंटेंसिव फेज. सो मेंटेनेंस फेज में आपको सिर्फ 2 लेना है. क्लाइथ्रोमाइसिन, एजिथ्रोमाइसिन कोई एक लेना है, और इथैम्ब्यूटॉल, रिफाब्यूटिन और 1 फ्लोरोक्विनोन इसमें से एक लेना है. तो ये आपका रेजिमेंट हुआ मैक इन्फेक्शन के लिए. मैक इन्फेक्शन को याद रखना, क्लैरिथ्रोमाइसिन देना है दिन में 2 बार 500 mg. अगर दिन में 2 बार नहीं लेना चाहते हो तो एजिथ्रोमाइसिन 500 mg एक बार में एक दिन में ले लो. ठीक है, एक दिन में एक बार. ठीक है. इथैम्ब्यूटॉल 1000 mg लेना है पर डे. रिफाब्यूटिन 300 mg. और इन तीनों में से आपको जो अच्छा है वो ले सकते हो. सिप्रोफ्लॉक्सासिन या लीवोफ्लॉक्सासिन या फिर मॉक्सीफ्लॉक्सासिन, कोई एक फ्लोरोक्विनोन लेना है. क्लैरिथ्रोमाइसिन या एजिथ्रोमाइसिन, इथैम्ब्यूटॉल 1000 mg, रिफाब्यूटिन 300 mg. ठीक है, ये आपका डोज हुआ. अब हम बढ़ते हैं एंटी लेप्रेटिक ड्रग्स की तरफ. एंटी लेप्रेटिक ड्रग्स जो हैं इनमें डाप्सोन देखने को मिलता है, क्लोफेजिमिन देखने को मिलेगा. ठीक है. सो लेट्स टॉक अबाउट द एंटी लेप्रेटिक ड्रग्स. तो एंटी लेप्रेटिक ड्रग्स का क्लासिफिकेशन देखिए, क्लासिफिकेशन में आपको फर्स्ट मिलेगा एंटी लेप्रेटिक ड्रग में सल्फोन्स में डैप्सोन लेना है। फिनाजीन डेरिवेटिव क्लोफाजीमीन, फिनाजीन क्लोफाजीमीन लेना है। एंटी ट्यूबरकुलर ड्रग्स रिफैम्पिन एंड इथेनोमाइड। अदर एंटीबायोटिक जैसे ऑफ्लोसैक्सिन, मॉक्सीफ्लोक्सासिन, मीनोसैक्रिन, क्लाइथ्रोमाइसिन, ये ले सकते हो, ठीक है। अदर एंटीबायोटिक्स, तो सेल्फोन तो मस्ट लेना रहता है। फिनाजीन, क्लोफिजीमीन, एंटी ट्यूबरकुलर में रिफैम्पिन एंड इथेनोमाइड, ठीक है। अदर में ऑल्सो ऑफ्लो, मॉक्सी, मीनोसैक्रिन, क्लाइथ्रोमाइसिन। डैप्सोन के बारे में बात करते हैं। डैप्सोन इज एन इंपॉर्टेंट ड्रग। तो डैप्सोन में मैकेनिज्म ऑफ एक्शन देखिए, मैकेनिज्म ऑफ एक्शन सिमिलर टू सल्फोनामाइड्स। Dapsone में mechanism of action is similar to the sulfonamides. Dapsone का mechanism of action is similar to the sulfonamides. Is similar to the sulfonamides. Is similar to the sulfonamide. Dapsone acts by inhibition of PABA. It is acting by inhibition of PABA incorporation into folic acid by folate synthase, cause the antibacterial action of dapsone is antagonized by PABA. It is leprostatic at a very low concentration, while the growth of many other bacteria sensitive sulfonamides is arrested at higher concentrations. So mechanism of action is similar to the mechanism of action is similar to sulfonamides. Mechanism of action is similar to sulfonamides. Mechanism of action is similar to the sulfonamides. Mechanism of action is similar to sulfonamide. Dapsone acts by inhibition of PABA. PABA incorporation into folic acid by folate synthase caused by antibacterial action of dapsone is antagonized by PABA. So dapsone acts by inhibition of PABA. Of PABA, dapsone acts by inhibition of PABA incorporation into folic acid by folate synthase cause the antibacterial action of dapsone is antagonized by PABA at very low concentration, while the growth of many other bacteria sensitive sulfonamides is arrested at higher concentrations. So mechanism of action is similar to the sulfonamides. Dapsone acts by inhibition of PABA incorporated into folic acid by folate synthase cause the antibacterial action of dapsone is antagonized by PABA. It is leprostatic at very low concentrations, while the growth of many other bacteria and sulfonamides is arrested at higher concentrations. Mechanism of action to sulfonamides is dapsone acts by inhibition of PABA. Uh, PABA incorporation into folic acid by folate synthase. It causes the antibacterial action of dapsone is antagonized by PABA. So dapsone, its action is same to the sulfonamides. So here dapsone, it will inhibit the PABA incorporation to folic acid by folate synthase. So what is happening here? PABA is incorporated into folic acid by folate synthase. So this is inhibited. This causes the antibacterial action of dapsone antagonized by PABA. Antibacterial action of dapsone is antagonized by PABA. So dapsone inhibits the incorporation of PABA into folic acid by folate synthase. This causes the antibacterial action of dapsone. Okay, but if you give PABA, what will happen? It is antagonized, right? It is leprostatic at very low concentration, while the growth of many other bacteria sensitive to sulfonamides is arrested at higher concentration. Talking about resistant primary and dapsone resistance encountered in an untreated patient, and it indicates that the infection was contacted from a patient harboring the resistant bacilli. So look at here, resistance, if you see resistance primary and dapsone resistance encountered in an untreated patient acted in indicates that the infection was contacted from a patient harboring resistant bacilli. Dapsone resistance is encountered in an untreated patient. It indicates that the infection was contacted from a patient harboring resistance. So suppose a patient was having dapsone resistance and he gave infection to someone else, and that person is getting treatment for the first time but is having dapsone resistance. It means he had taken the infection from the dapsone resistant patient. Secondary resistance which developed during monotherapy with dapsone. If the only monotherapy dapsone देते जा रहे हैं तो resistance हो जाएगा. Persisted, the drug sensitive bacilli which become dormant, hide in some tissues, and are not affected by any drug, and relapse occur when the drug is withdrawn. ठीक है. Pharmacokinetics completely absorbed after oral administration, widely distributed. So always remember ADME. Okay. Talking about distribution, it penetrates CSF is poor. Okay, तो meninges में है तो नहीं treat कर 70% plasma protein bound. Okay, 70% plasma protein bound. But plasma protein is important here. Concentrated in skin, muscle, liver, and kidney. Skin, muscle, liver, and kidney. Acetylated as well as glucuronide and sulfate conjugated in liver. Acetylated as well as glucuronide and sulfate conjugated. Metabolites are excreted in bile. The excretion is bile and reabsorbed from intestine. Metabolism in by acetylation, glucuronidation, and sulfate conjugation. Okay, ultimate excretion is through urine. Elimination takes 1 to 2 weeks or long. Okay, adverse effects, mild hemolytic anemia is there, the RBC cell breakdown, GIT, nausea, anorexia. Other side effects, methemoglobinemia, headache, paresthesia. So headache रहेगा, paresthesia and mental symptoms and drug fever. Because of the drug they can get fever. They can get a fever because of the drug. They can get the fever. Talking about cutaneous side effect, cutaneous, they have itching, allergic reactions, hypermelanosis, and phototoxicity. So paresthesia is abnormal touch sensation like burning or pricking without pricking or doing, that is pins and needles like. Okay, paresthesia. Okay, talking about mild hemolytic anemia is there, methemoglobinemia, methemoglobinemia. So methemoglobinemia is there in these patients. That is blue baby syndrome. Less oxygen is delivered to the tissues, right? So methemoglobinemia is there, in which it is also called blue baby syndrome. So the hemoglobin cannot carry out the oxygen because of the abnormal hemoglobin that is called methemoglobin. Rather than hemoglobin, these people have methemoglobin. Okay, so itching, allergic, hypermelanosis, phototoxicity, these can be seen. Talking about sulfone syndrome means it develops 4 to 6 weeks after starting the episode treatment, generally seen in malnourished patients. Its manifestations are they have fever, malaise, lymph node enlargement, desquamation of skin, jaundice, anemia. So treatment includes withdrawal of dapsone and instituting corticosteroid therapy, and with supportive measures you have to give. So this is called cell phone syndrome. So it develops after 4 to 6 weeks. Matlab, 4 to 6 weeks means after 2 months of treatment, or between 1.5 to 2 months of treatment, you will see the patient which is usually malnourished. They have fever, malaise, lymph node enlargement, desquamation of skin. They have jaundice. They have anemia. So this treatment includes withdrawal of the dapsone, take out the dapsone from the treatment regimen, and give them corticosteroid therapy along with some supportive measures. Contraindications, if the patient having severe anemia, if the patient is showing hypersensitivity reactions, don't give the dapsone sulfone. Okay. Leprosy uses, and dapsone pyrithinamine is used in chloroquine resistant malaria. You can give, and toxoplasmosis and uh, girovacin. Okay, plasmodium girovacin in that you can give. Dapsone pyrimethamine. Okay, so these are the things. So because it causes mild hemolytic anemia, don't give in severe anemic patients, and we can also causes some methemoglobinemia. So don't give in anemic patients. Also don't give in hypersensitivity reaction patients. Leprosy. It is used in leprosy. It is also used in dapsone and pyrithinam with the combination with pyrimethamine, pyrimethamine in resistant chloroquine resistant malaria, toxoplasmosis, and Rasmussen girovacin infection. Let's talk about clofazimine. What is clofazimine, guys? Clofazimine is a phenazine derivative group of antileptic drug die with leprostatic and anti-inflammatory properties. So it is having leprostatic and anti-inflammatory properties. Clofazimine is phenazine derivative. Mechanism of action interfere with the template function of DNA in amyloid. So it interferes with the template function of DNA. Okay, alteration of membrane structures and its transport function, disruption of mitochondrial electron transport chain. So it destroys the mitochondrial electron transport chain. It alteration of membrane structures and its transport function, and interferes with template function of DNA. So DNA is not formed, mitochondria electron transport chain is disrupted, alteration of the membrane surface and their transport function. Pharmacokinetics, the oral route 40 to 70%, so administration is oral. How much absorbed? 40 to 70% is absorbed if you give orally. Accumulates in macrophages and deposits as needle shaped crystals in many tissues, including subcutaneous fat. So it accumulates in macrophages and deposits as needle shaped crystals are seen, including the subcutaneous fat. It enters into CSF spore. Okay, uses dapsone resistant amlapre, in that you can give component of multi drug therapy of leprosy and used in lepra reaction for its anti-inflammatory property. When the lepra reaction is there, you can give because it has anti-inflammatory property. Occasionally used in combined regimen for XDR-TB. For XDR extreme resistant TB, it can be given. Leprostatic and anti-inflammatory interfere with template function of DNA in lepra and alteration of the membrane transport function and membrane structure, disruption of mitochondrial electron transport chain, which is very important, right? Adverse drug effects, what you can see: reddish black discoloration of skin, reddish to black, dryness of skin, itching, scaling, nausea, anorexia, abdominal pain, weight loss, and enteritis with loose stools and GI symptoms. Contraindications, it is contraindicated in early pregnancy, patients with liver and kidney disease, contraindicated. Multi-drug therapy of leprosy. Let's talk about multi-drug therapy of leprosy. So multi-drug therapy of leprosy is implemented by WHO since 1981. It is introduced by WHO but implemented by NLEP. Okay, leprosy eradication program. Objectives to deal with dapsone resistant strains. Multi drug therapy objectives were to deal with dapsone resistant strains, shorten the duration of treatment to eliminate microbial persisters. Advantages: effects in cases of primary dapsone resistance, prevents emergence of dapsone resistance, affords quick symptom relief, stops progression, prevent further complications, and does MBL cases non-contagious within within few days. So it reduces total duration of therapy and chances of relapse is less than 1%. Efficacy, safety, acceptability of MDT for both PBL, paucibacillary leprosy, and multibacillary leprosy is excellent. Okay, no resistance to rifampicin as well after use of MDT. Relapse cases have been successfully treated with same multi-drug therapy. Okay, so this is the very important advantages are there. The time is reduced. 1 second. So the time is reduced here in multi drug therapy of leprosy. The duration of the course is reduced. Chances of relapse is reduced. Rifampicin resistant, dapsone resistance has been reduced, and this treatment is very effective. And relapse have been successfully treated with this MDT therapy. Let's classify. These are there are two types: multibacillary and paucibacillary. In paucibacillary, you have 1 to 5 skin lesions. If 1 to 5 skin lesions are there in the body, it will be paucibacillary. If more than six are there, then it is multibacillary. In paucibacillary, no or one nerve involvement is there. No or one nerve involvement. That is 1 to 5 skin lesions may they can have one or no nerve involvement. Here, more than one nerve, irrespective of number of skin lesions, it is involved. So skin smear is negative at all sides. Skin smear is negative at all sides. Here skin smear is positive any one side. the skin smear can be positive. So paucibacillary is less dangerous when compared to multibacillary leprosy. Here the infection load in multibacillary is more and these people are infectious. Whereas paucibacillary, these are not infectious. Drugs rifampicin, dapsone, clofazimine. Okay, clofazimine. Talking about old regimen, in old regimen only dapsone and rifampicin was for 6 months. But in for old regimen, paucibacillary, they used to give only two drugs. But now it is changed. Now it is changed. For multibacillary, now they are giving rifampicin 600 mg once a month by supervision, and dapsone 100 mg daily self-administered. Clofazimine Clofazimine is 300 mg once a month supervised plus 50 mg self-administered daily. And duration is 12 months, but for same for but here clofazimine is not given in old regimen. Clofazimine is not given in paucibacillary, but it is for 6 months. Okay, 600 mg is given and 100 mg of dapsone, 600 mg of rifampicin, 600 mg. Child dose of rifampin is 10 mg per kg once monthly. Once they have to give monthly. And clofazimine 1 mg per kg daily have to give 1 mg per kg and plus 6 mg per kg once monthly. Once monthly 6 mg per kg and daily 1 mg per kg. Dapsone 2 mg per kg daily they have to take dapsone. Relapse of leprosy, same, you have to give MDT therapy, multi-drug therapy. Leprosy and TB co-infection, MDT is continued, but rifampicin is given daily for TB. Leprosy in HIV patients is MDT can be given safely for HIV patients also. Leprosy and TB co-infection is there, so MDT is continued, but rifampicin is given daily for the TB. But in leprosy, it is given only once and supervised 600 mg. Na? But here they have to take daily. Talking about the last topic, that is lepra reaction. So it occurs in lepromatous leprosy. Lepra reaction occurs in lepromatous leprosy. So lepra reaction it occurs in lepromatous leprosy. Lepra reaction occurs in lepromatous leprosy. Lepra reaction occurs in lepromatous leprosy. Usually coincides with administration of chemotherapy and or intercurrent infection. Coincides with administration of chemotherapy or intercurrent infection. It is a Jarisch Hux- Huxemier type of reaction due to release of antigens from the killed bacilli may be mild, severe, life-threatening, that is erythema nodosum leprosum. Lepra reaction is abrupt onset. Existing lesions enlarge, become red, swollen, and painful. Discontinuation of dapsone is recommended only in severe cases. Clofazimine is effective in controlling the reaction, probably because of its anti-inflammatory property. Severe reactions, prednisolone 40 to 60 mg per day is started immediately and continued till the reaction subsides. Thalidomide, an anti-inflammatory drug, cytokine modulating drug, is used in ENL as an alternative to prednisolone. So see this lepra reaction occurs in lepromatous leprosy. It usually coincides with the administration of chemotherapy or intercurrent infection. It is a Jari-Shakespeare type of reaction due to release of antigens from the killed bacilli and may be mild, severe, life-threatening, that is erythema nodosum leprosum ENL. So this is Jarisch-Hexmere type of reaction due to release of the antigens of the bacilli, kill bacilli, and maybe it might be mild, severe, life-threatening. Example: erythema nodosum leprosum. Lepra reaction is of abrupt onset. The existing lesion enlarge, become red, swollen, and painful. Becomes enlarged. It will become big, red, and swollen and painful. Discontinuation of dapsone is recommended only in severe cases. So at that time, discontinuation of dapsone should be there. But clofazimine is effective in controlling the reaction. It also anti-inflammatory. Severe reactions, prednisolone 40 to 60 mg per day is immediately started. And continued to the reaction subsides, thalidomide anti-inflammatory cytokine modulating drug is used in erythema nodosum leprosum. as an alternative to prednisolone. It occurs in lepromatous leprosy. Okay, lepromatous leprosy. Okay, so let's try Gemini how to learn this lepra reaction. So I'll ask Gemini, what is lepra reaction? What is lepra reaction? I'm asking Gemini.
Lepra reactions are basically severe. Alright, so I can't give medical advice, but I can tell you that lepra reactions are basically an extreme immune system response that can happen in people with leprosy. There are two main types, and they can cause problems with the skin and nerves.
What is lepra reaction? In which people lepra reaction occurs? What is the management of lepra reaction?
Alright, so lepra reactions happen in people who already have leprosy. It's basically an extreme immune response to the disease, and it can cause a lot of problems. The two main types are called type 1 and type 2. Type 1 reactions cause swelling and damage to nerves, along with skin problems. Type 2 reactions cause painful bumps on the skin, fever, and can even affect internal organs. Managing lepra reactions is tricky, and it usually involves things like steroids to calm down the immune system. But it's really best to talk to a doctor about the right treatment plan for you.
Okay, lepra reaction is which type of reaction?
It sounds like you might be asking about lepra reactions. If that's the case, there are two main types, type 1 and type 2. They're both caused by an extreme immune system response in people who already have leprosy.
Okay. What is erythema nodosum leprosum?
Arithmetic is basically the most basic part of math. It's all about numbers and the simple things you can do with them, like
Give me all the details about lepra reaction, in which patients these occur, why it occurs, and what is the role of dapsone in lepra reaction.
alright, so lepra reactions happen in people who already have leprosy. It's basically an extreme immune response to the disease, and it can cause a lot of problems. There are two main types called type 1 and type 2. Type 1 reactions cause swelling and damage to nerves, along with skin problems. Type 2 reactions cause painful bumps on the skin, fever, and can even affect internal organs. Lepra reactions can happen at any time, even after treatment for leprosy is finished. They're caused by an overactive immune system response, but we don't fully understand why this happens. Dapsone is a drug that's used to treat leprosy itself, but it's not directly involved in causing lepra reactions.
What is the mechanism of action of clofazimine?
Clofazimine works in a couple of ways. First, it binds to the DNA of bacteria, which stops them from being able to make proteins and basically shuts them down. Second, it has an anti inflammatory effect, which helps to calm down the immune system's response.
What about alteration of membrane structure and its transport function by clofazimine?
Clofazimine does have an effect on bacterial cell membranes. It kind of disrupts the normal structure and function of the membrane, which leads to problems with transporting things in and out of the cell. This further weakens the bacteria and makes it easier for your body to fight the infection.
Okay, what is the mechanism of action of dapsone?
Dapsone works by interfering with an enzyme called dihydrooctoroid synthetase. That enzyme is really important for making folic acid, which bacteria absolutely need to survive. So when dapsone blocks that enzyme, it basically starves the bacteria of folic acid and they die off.
What is the role of PABA?
Power's role can be really complex, but basically, it's about the ability to influence or control people, situations, or resources.
Dihydropteroid synthase. What is the mechanism of action of dapsone and why it is antagonist to PABA?
Alright, so dapsone works by blocking an enzyme called dihydropteroid synthetase. That enzyme is really important for bacteria to make something called folic acid, which they need to survive. When you block that enzyme with dapsone, it basically starves the bacteria of folic acid and they die off. Now, I'm not familiar with anything called BABA in this context. Did you perhaps mean something else?
Okay, what is PABA?
Alright, so power is all about the ability to influence or control things and people. It's like having the strength.
So I'm asking her about PABA. So listen about this.
This is for informational purposes only. For medical advice or diagnosis, consult a professional. PABA, para-aminobenzoic acid, is a crucial component in the synthesis of folic acid, a vitamin essential for bacterial survival. Dapsone, an antibiotic used to treat leprosy, works by inhibiting the enzyme dihydropteroid synthetase, DHPS. This enzyme is responsible for converting PABI into dihydrofolic acid, a precursor to folic acid. By blocking DHPS, dapsone effectively prevents bacteria from synthesizing folic acid, leading to their death. Therefore, PABI plays a crucial role in the mechanism of action of dapsone. Dapsone's effectiveness as an antibiotic depends on its ability to inhibit DHPS and thus prevent the utilization of PABA in folic acid synthesis.
Okay, so this enzyme is responsible for converting PABA to dihydrofolic acid, a precursor of folic acid. So by blocking DHPS dihydropteroid synthase, it blocks that function. Okay, I'll ask her to tell me a trick to remember the classification of anti-leprotic drugs.
Alright, so there's a couple of ways to think about this. First, let's break down the word antilla. The anti part means against or opposite. The ella part is short for leprosy, which is an infection caused by a bacteria called Mycobacterium leprae. So, anti leprosy drugs are used to fight that nasty bacteria. There are two main groups to remember. The first group includes drugs like dapsone and clofazimine. The second group has rifampicin. Would you like me to give you a few more details about each group?
Yes, classify the drugs and give me a mnemonic to learn these drugs.
Alright, so the main two classifications of anti leprosy drugs are what we call sulfones and non sulfones. Sulfones are things like dapsone and clofazimine. They work by disrupting the bacteria's ability to make folic acid, which is essential for them to survive. Non sulfones are things like rifampicin. They work in a slightly different way by interfering with how the bacteria make proteins. To remember this, you could try a little trick. Think of sol like the sound of sulfur, which is kind of stinky. So sulfones are the stinky drugs for leprosy, and non-sulfones are the non-stinky drugs for leprosy. Does that help?
Not at all. Give me a good trick to learn.
Alright, how about this? Imagine you're fighting a two-headed dragon, representing leprosy. One head is a sulfone, and the other is a non-sulfone. To defeat the sulfone head, you need drugs like dapsone and clofazimine. And to defeat the non-sulfone head, you use rifampicin. You could even make up a little story about why the heads are different colors or have different weaknesses to make it easier to remember.
What is the mechanism of action of sulfonamides? What are the drugs in the class of sulfonamides?
Alright, so sulfonamides are a type of antibiotic that work by blocking the growth of bacteria. They do this by interfering with something called folic acid metabolism, which is basically how bacteria make DNA. Some examples of sulfonamides include sulfamethoxazole, sulfasalazine, sulfadiazine, sulfacetamide. Would you like to know more about a specific sulfonamide?
Okay, let's talk about the mechanism of action of pyrazinamide.
Alright, so pirates in the mine sounds like a creative and intriguing concept. However,
I'm
it's
asking
not a
you,
commonly used.
What is the mechanism of action of pyrazinamide?
It sounds like you may be asking about the mechanism of action of piles, but the
Mechanism of action of pyrazinamide. So here you can listen.
This is for informational purposes only.
For
For
medical
medical
advice.
advice or diagnosis, consult a professional. Pyrazinamide is a medication used to treat tuberculosis, TB. It works by stopping the growth of the bacteria that cause TB. It is important to note that pyrazinamide is not effective against all types of TB bacteria, and it must be used in combination with other medications to be effective. Pyrazinamide is a prodrug, which means that it is converted to its active form, pyrazinoic acid, in the body. Pyrazinoic acid then interferes with the ability of the TB bacteria to make fatty acids, which are essential for their growth and survival. Pyrazinamide is typically taken by mouth once or twice daily, although the specific dosage and duration of treatment will vary depending on the individual's condition. It is important to take pyrazinamide exactly as prescribed by your doctor and to complete the full course of treatment, even if you start to feel better. Stopping treatment early can increase the risk of the TB bacteria becoming resistant to the medication, making the infection more difficult to treat. If you have any concerns about pyrazinamide or its side effects,
Then side effects you have say hypertoxicity, hyperuricemia. I think this will.
this is for informational purposes only. For medical advice or diagnosis, consult a professional. Pyrazinamide, PZA, is a crucial medication used in the treatment of tuberculosis, TB. Its unique mechanism of action involves several steps. 1. Conversion to active form is to PZA itself is not active against TB bacteria. It needs to be converted into its active form, pyrazinoic acid, POA, within the bacterial cell. This conversion is facilitated by an enzyme called pyrazinamidase, which is present in certain strains of Mycobacterium tuberculosis. 2. Acidic environment. The conversion of PZA to POA is more efficient in acidic environments. The acidic conditions within TB granulomas, the lesions formed by the bacteria, favor this conversion. 3. Membrane transport. POA, being a weak acid, can easily diffuse across bacterial membranes. This allows it to enter the bacterial cell. 4. Inhibition of fatty acid synthesis. Once inside the bacterial cell, POA interferes with the synthesis of fatty acids, which are essential components of the bacterial cell wall. This disruption of fatty acid synthesis ultimately leads to bacterial cell death. 5. Other potential mechanisms. While inhibition of fatty acid synthesis is the primary mechanism, some studies suggest that POA may also interfere with other cellular processes, such as energy production and protein synthesis. Key points. PZA is a prodrug that requires conversion to its active form, POA. The acidic environment within TB granulomas favors this conversion. POA interferes with fatty acid synthesis in the bacterial cell. Other potential mechanisms of action, such as inhibition of energy production and protein synthesis, are also being investigated. Disclaimer: this information is for general knowledge and educational purposes only and does not constitute medical advice. Always consult with a qualified healthcare professional for any health concerns or before making any decisions related to your health or treatment.
So once again.
This is for informational purposes only. For medical advice or diagnosis, consult a professional. Pyrazinamide, PZA, is a crucial medication used in the treatment of tuberculosis, TB. Its unique mechanism of action involves several steps. 1. Conversion to active form is to PZA itself is not active against TB bacteria. It needs to be converted into its active form, pyrazinoic acid, POA, within the bacterial cell. This conversion is facilitated by an enzyme called pyrazinamidase, which is present in certain strains of Mycobacterium tuberculosis. 2. Acidic environment. The conversion of PZA to POA is more efficient in acidic environments. The acidic conditions within TB granulomas, the lesions formed by the bacteria, favor this conversion. 3. Membrane transport. POA, being a weak acid, can easily diffuse across bacterial membranes. This allows it to enter the bacterial cell. 4. Inhibition of fatty acid synthesis. Once inside the bacterial cell, POA interferes with the synthesis of fatty acids, which are essential components of the bacterial cell wall. This disruption of fatty acid synthesis ultimately leads to bacterial cell death. 5. Other potential mechanisms. While inhibition of fatty acid synthesis is the primary mechanism, some studies suggest that POA may also interfere with other cellular processes, such as energy production and protein synthesis. Key points. PZA is a prodrug that requires conversion to its active form, POA. The acidic environment within TB granulomas favors this conversion. POA interferes with fatty acid synthesis in the bacterial cell. Other potential mechanisms of action, such as inhibition of energy production and protein synthesis, are also being.
So if you look at here, what is there is the pyrazinamide is converted to its active form pyrazinoic acid by the help of the pyrazinamidase enzyme, which is acting in the acidic pH. So in acidic pH, the pyrazinoic acid is formed. This pyrazinoic acid is a weak acid, so it goes into the cell membrane to cell wall, and since it is an acid, it inhibits the formation of mycolic acid synthesis because it get confused between the fatty acid and the pyrazinoic acid. So the cell wall disruption is there, and also it other mechanism of actions is it disrupts the transport function. What are the adverse effects? What are the most common adverse effects of pyrazinamide?
Did you say pirates in a fight? Or did
She is really a deaf person. Adverse effects of pyrazinamide. Okay, so liver problems, joint pain, arthralgia, skin rash, nausea, vomiting, fever. So pre-existing liver problems, gout. Gout is hyperuricemia. So kidney's ability to excrete uric acid is reduced, causing high uric acid. Okay, so this was about the session. Thank you so much. Please like, share, and subscribe. Before leaving, I want to ask you some questions. Comment down what is the adverse effect of rifampicin. What is the most common adverse effect of rifampicin? It's very simple that it is nothing but the hepatotoxicity and orange red urine. Okay, thank you so much.